Hello, everybody. Welcome to Conversations in Interventional Cardiology. My name is Frank Ng. I'm the Associate Editor of JSCAI, Division Chief of Pediatric Cardiology at the UC Davis Heart Center. And I'm honored to represent JSCAI and the Editor-in-Chief, Dr. Lansky. You will find us online at jsci.org and follow us on X, or formerly known as Twitter, at myjsci. JSCAI is the home of all the official SCAI documents. We're here today to discuss an important document published in JSCAI entitled PICS-AEPCS-CSANZ-SCAI-SOLACI Expert Consensus Statement on Cardiac Catheterization for Pediatric Patients and Adults with Congenital Heart Disease. All those acronyms are the different societies that have endorsed this document or partner with the authors. I'm joined by an esteemed panel of SCAI leaders and experts, the movers and shakers of the pediatric interventional community here. Dr. Holzer, who's the lead author of this paper, is the director of the Cath Lab at UC Davis in Sacramento. Dr. Aimee Armstrong is the director of the Cath Lab in Interventional Therapies at Nationwide Children's Hospital, professor of pediatrics at Ohio State University College of Medicine in Columbus. Sir Shakeel Qureshi, professor and consultant pediatric cardiologist at Evelina Children's Hospital and Guy's and St. Thomas Hospital Trust in London, UK. And then finally, last but not least, Dr. Mohammad Alnoor, editorial fellow for JSCAI and currently staff at UC Davis Pediatric Cardiology. So thank you very much to everyone who's joined us. I'm going to turn this time to Dr. Holzer to start his introduction to the paper. Dr. Holzer.
Okay. The reason we came up with this project that dates back about 3 years ago was that really in pediatric and adult congenital cardiac catheterization, we did really not have any available document on standards of cardiac catheterization. There was no comprehensive document, and most of the societal position papers and consensus documents, they were somewhat vague and really had very geographically limited buy-in or adoption. The only document there was dated back about 10 years to 2012. And in the standards document, there was just 4 pages devoted to pediatric and congenital cases. Now, that puts really the congenital community in a very difficult position because we sort of act in a legal and practice vacuum. And when we try to negotiate with hospital leadership to get the appropriate setup to do what is best for our patients and safest for our patients, we really did not have any document to support a lot of what we were asking for. So the goals for this project was to develop a multi-societal comprehensive cath lab standards document focused on pediatric patients and adults with congenital heart disease, based on expert consensus in areas where there was no higher level evidence available, which is a lot for what we do in the congenital field. And we want to develop standards that, if feasible, are two-tiered and differentiated between acceptable and ideal standards that are applicable across countries, continents, and in different healthcare settings, and with specific accommodations for resource-limited environments. And in all what we did in this document, the primary consideration for all was safety and quality of care, and it was not designed to automatically endorse everything that we were presently doing. Now, this was really a truly global effort. The writing committee had members from 15 different countries, and straight from the get-go, we involved many societies. So we had endorsement for 5 large global societies in different regions of the world. We had endorsement by the leading PICS society with a worldwide congenital society. And then we had 2 other societies and endorsed a document which were allied professional societies. Now, these were sort of the different sections of the document. We had 14 main sections differentiated between anything from cath lab management to anesthesia to pre and peri-procedural management. And importantly, for many of these sections, we had two specific subsections that we felt were important, where sometimes there are differences between what we do with the ordinary pediatric patients. A, we want to make sure we make recommendations for resource-limited environments, and B, we differentiate when there are other requirements for adult congenital heart disease patients. Now, it is beyond the scope of this really to go into details of our 70-page documents, but I want to highlight two areas where we really try to focus on what recommendations we can make. One was, for example, the surgical backup, which was a deficiency for our field for a long time. So we differentiated between the type of requirements for that is procedure specific and then supplemented that with specific patient characteristics where additional requirements are needed. In addition, we defined that obviously in an ideal scenario, we have a congenital cardiac surgeon for all backup, but at a very minimum, we required surgery backup to be provided by surgeons who have done at least in the last 12 months a similar type of surgery in a similar patient with a similar overall anatomy. Another important recommendations focused on procedures performed in adult congenital heart disease patients. And here we differentiated between sort of the training background for those performing these procedures. But it was not just about who is doing the procedures. It was out how do we go about by discussing them, for example, in combined case management conference, who needs to be part of these discussions and so forth. And we supplemented these with sort of minimum interventional procedure-specific requirements and made recommendations of the ideal case volume we should do when we do adult congenital heart disease procedures. There were, of course, other impactful or potentially impactful recommendations, and just a few examples. For example, focus on procedure room size, and as you all know, in congenital procedures, we often require a lot of more room for those ones. The time period for replacing X-ray equipment, given that our patients are prone to radiation, the effects of radiation over their lifetime, the minimum number of congenital cases for the cath lab staff, and obviously issues like the inventory management and so forth. There were many challenges in this project, but the most important part was not trying to focus on everything we're doing right at the present time, and which is a little bit sort of protectionism, but trying to really go above and beyond and emphasize safety and what is best for our patient. And that sometimes was a difficult road we had to travel, but I believe we arrived at very, very good recommendations in this regard. Okay, back to you, Frank.
Well, thank you for your presentation. I know this was a Herculean effort on your part, Ralf, and I know that all the authors really worked hard to pull this together. We have three panelists for this discussion, and Dr. Qureshi, if my math is correct, you've been in the field for 36 years. Dr. Armstrong, you've been in the field for almost 20 years, and I know Dr. Alnoor this is his first year. So we have a wide range of experience and sort of various stages of careers over this long span of time. I'd like the panelists to chime in on, give us a perspective from your stage in career, how this paper will impact you going forward, or how, if this paper was available when you first started, could have changed or impacted your career. So, Mohammad, why don't you start with it?
Thank you, Dr. Ng, for the question. I think as a junior faculty just starting off, I think this was a type of document that's really helpful to set a framework and have a reference to for me to be able to see how to best run a cath lab and how to really hire on and maintain a staff to make a successful cath lab. I think as a fellow, it's something that I underappreciated, being the behind the scenes work that goes along to maintaining this service for our patients. And from the clinical side of things, I think it does set a framework on where some of our work should be focused. I think I paid a lot of attention to the appendices and resources available for the training of fellows to at least have some basis of evaluation and goals for them. And additionally, I think the sections on adult congenital heart disease, hybrid procedures, and pedal procedures are ones that were important for me to see. And, as populations that we expect will need to have more interventions and increasing work there. So I think it also sets a kind of a pathway of where some of our research and clinical work should be focused also.
Aimee, you're almost 20 years into this business. Give us your perspective.
Thanks, Frank. Looking back on the last 20 years, I think there's 3 times that really stick out that this document would have been very, very helpful. The first is when I became a new cath lab director, because this really provides a blueprint for how your lab should be set up. Everything from how you do the staffing to the radiation shielding to the inventory management and risk mitigation. I mean, it's just so comprehensive that I think it would have been really helpful for me to go through all those different things and make sure that my lab was set up appropriately. And then the second one is when you're building a new cath lab. We just got done constructing 2 new cath labs. And this really provides a checklist where you could go through and make sure that you're setting your new lab up for success. And it includes everything from, like Ralf said, the size of the room to the X-ray equipment and all of the ancillary equipment that is necessary. So would have been very helpful for that. And then the other time is when we started an interventional fellowship. I think this gives you a guide to help determine if your program has the volume and the types of cases to train pediatric interventional cardiologists and or adult congenital interventionalists.
Yeah. Thank you, Aimee. Sir Shak, you've been in this business forever, and looking back at it, maybe you can provide a perspective of how this could have been helpful over the last 36 years, or how do you see this going forward?
If I go back, when I started my training, we had no clear idea of what numbers we were going to do, how we were going to assess our competence. There were no guidelines for anything really. It was all done on an apprenticeship basis. So we just, for interventions, we just assisted in the catheter lab, our seniors, and then gradually we were introduced to do first operator procedures. So there was no idea of numbers. I had no idea, or none of us had any idea of protection from radiation, for example. And so I have no hair on my legs as a result, because we were not protecting ourselves at all. That's an important area because, there are quite a few, not just pediatric, but adult cardiologists, interventionists around the world who have had health problems much earlier than they would have done if they had undertaken all the protection. It was really about just over 20 odd years ago, we started looking at what the numbers needed to be for us to gain experience and competence. Prior to that, in the UK and around Europe, for example, different from US and Canada, our whole training in a specialty could take anything up to 10, 11, 12 years before we were able to get into a senior consultant position. Then our European Working Time Director went the other way and reduced the training. And so we finished up in the middle somewhere trying to work out how to assess competence. And so this document, if this had been available to tell us how many years we needed to train for in subspecialization, what sort of numbers of different types of interventions we needed, then it would have been a really enormous guideline, really, in telling us how to become competent, never mind becoming really good at it. So this is the important area. And developing countries in particular, this is going to have an important way of guiding them, because they will have a lot of problems in gaining competence. So there's enormous amount of information in this document that will help them in particular.
Yeah, I think adding to that, just in the last decade or so, the evolving field of adult congenital heart disease and how adults might be approaching congenital heart disease, this could be also very helpful in shaping how the labs should be organized and developed for the adults too. Dr. Holzer, I know you spent a lot of time in this huge effort. How did you think through the workflow process and envision this outcome? And did it follow your expectations? And hearing some of the comments from the panelists, would you have made any changes in how you approached this paper?
I think that's a very good question. It was a very evolving target. The end product was nowhere near of that what I envisaged at the beginning, but that's the advantage when you have a large group of people, or very experienced people working on such a document, because you get so many great suggestions of how things can be modified and approached to the project. So you come up with some sort of preconception, but it never quite follows. It automatically has to evolve over time. And for example, we added substantial adult congenital heart disease experience as we progressed through the project, because we felt that was necessary. And again, that made to make a lot of modification. I think the topic you last addressed was probably one of the biggest challenges, to measure competency, because you have obviously the number problem. Numbers never define whether someone is competent or not, but on the flip side of it, there has to be a certain number where you say, what, in the best will of the world, that would be really concerning if someone practiced certain things, if you haven't had a certain experience. So we used like a composite in this document, where we said, look, we have a certain minimum case numbers, but those don't necessarily guarantee competence, and there's more above and beyond that you need for that one. So it has sort of involves both of these areas, but again, it's very difficult to move completely away from numbers. But on the other hand, you need them in some extent to prevent that people who really have not done anything and say, what, just because I've done a procedure here, I've done a lot of mitral valve interventions, I'm now going ahead and start a PUMI-Valve program, and I've never treated any patient with congenital heart disease, which really is happening and is a concern for our patients.
Yeah, I agree. I can see how this paper will be referenced a lot for the next decade and even longer. And some of this is going to be revolving around quality improvement and safety and so forth, especially for the hospital side of things, with administrators and so forth. So my question to the panelists and to the author, how can this paper be used to improve quality of care for our patients? And again, I know that we're all in different stages in career. The thinking through this is how do you look at this paper, and how will you use this in coordination with hospital administration when you're planning your cath lab? Is this something you think will be used a lot?
So many years ago, Frank, in terms of space requirements for pediatric cardiac catheter lab and the types of equipment, before we had any indication or guidance, it was really hit or miss. And it was around the time, I can't remember the exact year, John Cheetham wrote some recommendations of the space requirements. And in our unit, and then other people as well around UK and Europe, started using that sort of guidance with our administrators when we were planning catheter labs, space, as well as equipment. So this is, nowadays, it should really be almost taken for granted, but this document will help people in different countries at different stages of development to use as a guideline.
I agree with Shaq. The problem we don't really have any written laws how we should do things in our profession. So when we approach hospital administration, I think a document that's endorsed by many societies is probably the strongest argument we can make. This is what we need to practice safely for our patients. So it will be much harder for our administrators to ignore the things that we're asking for, but we can argue, look, this is for the safety for the patients, and we have a large number of international societies that endorse these type of recommendations. So we hope that makes certain things when it comes to specific equipment and other stock keeping and other requirements, that it makes it more easy for us to advocate for those things by our administrator.
Yeah, I absolutely agree. I think that, if for the future, as we advocate for infrastructure, this can be really helpful as a reference to hospital administration, because I know that a lot of times the administration look at the bottom dollar, right? And sometimes a pediatric cath lab or a congenital heart cath lab just require a lot more devices, sizes, because of the wide range of sizes we have to work with. Very different from the adult lab only. So I think that this will have a tremendous application in ACHD programs as well. Aimee, you work in a program where you have a very well-coordinated ACHD service. Can you see the your ACHD team utilizing this in a special way, or how do you see this apply in the ACHD world?
Well, I think we're all still trying to figure out the best way to train ACHD interventionalists. I think this gives very nice guidelines of volume numbers and things that need to happen during an ACHD interventional training program. So I think it will be very helpful for that. And the other thing I was going to say in terms of safety is I really appreciate the surgical backup section. I've had a number of conversations with surgeons over the years at different institutions about what type of backup we need, but there really wasn't anything to reference. And now we have that, and it's very comprehensive down to the different types of procedures and what is adequate and what is ideal. So I think that will be used a lot.
Yeah. As Shaq, you said, in many of the programs in other parts of the world, I can also see how this can be a nice guideline to how to set up things. And, we all acknowledge not everybody has the equal resources and there may be limitations, but it's nice to separate the what's ideal versus what is essential and so forth. So it's a nice guideline for that.
Frank, if I may, and that is some sort of an ideal that we will never achieve, I don't think. But if 30 odd years ago, I would have, if I had said, oh, we need some sort of a guideline document, everybody would have said, you're not going to achieve it. So an area that we are not going to achieve very quickly is, you asked briefly about quality of care and improvement. And how do units compare themselves in terms of standards? Well, they can only do that if you have data for your results and the numbers and compare them initially nationally and then internationally. So if in, I don't know, 10, 20 years, there's a database that everybody around the world can contribute to, then they can check almost themselves for standards and compare themselves against everybody else internationally. That's just a wish list.
Yeah.
Hugely important comment, because again, I think we emphasize that data is at the essence of anything. Anything to do with quality relies on data. And if you don't capture appropriately and adequately the data, you will never able to compare and achieve the improvement that you strive for. And I think it's work in progress, but we've come a long way over the last 20 years in this respect.
Yeah. Well, congratulations to you, Dr. Holzer, on this Herculean effort. And I can thank the panelists for taking time to join in on this discussion. Thank you, everybody.